now introduce the device programming and follow-up in left bundle area pacing. This introduction, I think Dr. John and Dr. Sayin, Dr. Rania, and Dr. Sasi also have a big effort to introduce what's mean by left bundle branch area pacing. Okay, what is the left bundle branch pacing? Left bundle is a novel conduction system pacing strategy for target the left bundle branch area to achieve physiological ventricular activation. The pacing lead is implanted deep into interventricular septum to capture left bundle branch distal to potential site of block, enabling effective capture of distal conductive system pacing. Physiological benefit result in more homogeneous left ventricular contraction and relaxation and compared to conventional biventricular pacing need to improve cardiac synchrony. What is the lead? We have here all companies start to have a new lead for left bundle like Surya S and Pytronic, using in longevity in Boston, and also Tendril in Abbott, and all these company have a stylet left bundle lead, but in Medtronic he had luminless lead. Okay, with special introduction sheath, had a deflectable sheath and non-deflectable sheath. Okay, the implantation approach, the lead position in the right ventricular system advanced deep into the interventricular septum to reach the left bundle branch area. Technical consideration requires specialized delivery sheath, as I told before, had non-deflectable and deflectable delivery specialized sheath. We have here in Egypt non-deflectable sheath only. Confirmation method successful placement is confirmed by characteristic ECG pattern, as Dr. Jun and Dr. Rusasi and Dr. Said told a lot of criteria for ECG. But here, left bundle branch area pacing criteria, at least one of the following criteria has to be met for left bundle branch area pacing. To be said that we have a successful left bundle branch area pacing in ECG criteria, we should have at least one of these criteria. In V1, right bundle branch morphology in V1, either QR or RSR dash pattern, confirm deep septal lead placement before performing this check. It means that LV activating period prior to RV. This criteria highly sensitive for left bundle branch area pacing, but not 100 specific. It is not, if not achieved, consider further lead rotation, as Dr. Mohamed Said informed us. Caution performing further screwing in case of impedance significant drop more than 200 ohm or current of injury less than 7 to 10 millivolt. Other things is the first criteria. Second criteria, a change in QRS appearance with change in output with unipolar pacing, with decreasing output, non-selective left bundle branch pacing transition to selective, or with decreasing output, non-selective transition to left ventricular septal pacing. Also, it is confirmed with Dr. Mohamed Said that when we decreasing the threshold, we want to achieve the latest, the smallest amplitude to capture the left bundle branch. And in V6, our wave peak time in V6 ideally less than 80 milliseconds, but this condition doesn't apply to patient with QRS morphology predominantly negative, or in patient with RS pattern in V6, and also in patient with pure left bundle. We can not depend on this criteria mainly. And the presence of left bundle potential on the lead recorded by EP recording system, as when we insert the lead, we connect the lead itself to the EP recording system. And here, what we will see during implantation on the lead itself, that this left bundle potential. Device programming, what is general consideration? Importance of proper programming. Effective conductive system pacing depend on not only successful implantation, but also on proper device programming to ensure patient safety and optimal therapy benefit. Device labeling, and this is very important, as all we know that we have conventional pacemaker battery and ICD and CRT, all this labeling. But in conductive system pacing, mainly either his bundle pacing or left bundle area pacing, we do not have a specialized battery or specialized device for this new implantation technique. So it's crucial to indicate the implanted device and patient card that a conductive system pacing lead is present and which port is connected to. And it's very important, and I will give you an example for this. Rule of 12 lead ECG, essential for recognize various type of capture, selective versus non-selective conduction system capture, myocardial capture, or another capture. Follow-up frequency recommended directly after implantation, then at least 1 to 3 and 6 months, followed by 6 months basis, may be more frequent than standard pacing due to potential lead issue. Classification and definition of left bundle. We have selective transition sign, modified the left ventricular activation time and predictor, left ventricular septal pacing, and all this, I think Dr. Mohamed Said and Dr. John already explained it. And here also, I think I will escape this picture, and then we enter in device programming and follow-up of left bundle. Lead pacing configuration. And here in image A, unipolar tip pacing and bipolar. Which configuration we should choose? Okay, if we see here in unipolar tip pacing, this it changed from non-selective in V1 here, from non-selective to selective when decreasing amplitude. And in bipolar pacing, okay, if we start here in 3 volt, okay, that means that we have right ventricular LV and left bundle pacing. Okay, as you see in V1, it is Q, then R, and a little bit Y complex. When decreasing amplitude to 1, we have initial R and peak R dash in V1. And in decreasing amplitude to 0.5, we have selective V initial R and not differ from non-selective pacing. But here, if we use a bipolar configuration, we have a peak area of activation, of stimulation. But when you use unipolar, we more go for selective. Okay, so what is the requirement for what is the recommendation in left bundle area pacing? We prefer to do a unipolar pacing configuration in left bundle lead. Okay, AV optimization, correcting left bundle branch in patient with left bundle branch block, left bundle area pacing, aim to restore normal ventricular activation. The AV delay adjusted to ensure the paced wavefront from left ventricular effectively merge with the intrinsic right ventricular activation, thereby shortening QRS duration. So in patient with left bundle branch block, and we decided to insert implant left bundle branch area pacing, we should decrease the AV delay, okay, like CRT. Okay, so to make sure that we activate left bundle before right bundle. Avoiding right bundle branch block pattern too short of an EV delay can lead to right bundle branch block pattern due to the paced LV activation wavefront being to early interfere with the intrinsic RV activation and optimizing hemodynamics. Proper EV delay optimization can improve for sure the LV function. Crucial impact to correct left bundle, short EV delay, right bundle branch block, long EV delay way intrinsic conduction with left bundle branch block. Sensing and output, sensing vector bipolar is preferred, and output voltage or amplitude should be double the threshold voltage, and all these things, impulse duration 0.4 millisecond, and automatic capture control set to monitor automatic once accuracy confirmed, and this will increase the battery longevity. Device programming strategy for heart failure patient. I think you know what's meant by hot CRT and lot CRT, that we replace the conventional RV lead by either his bundle pacing or left bundle. If we, in addition to LV pacing lead, that mean his bundle plus LV pacing lead, CS lead, it names hot CRT, left bundle branch area pacing lead plus CS lead, it is lot CRT. And all follow-up schedule, everyone, as I told before, all these things also I told before. Okay, I will present one case, a real case. A 27-year-old female patient presents with complete heart block and with infrahesian block. This is the ECG for her. Okay, wait. This our technique. This the fluoro image in REO. You saw the sheath here on the septum, and we inject contrast. Then we deliver our lead in LEO. Okay, at here, if you, I think you are seeing the contrast and the lead already penetrating the septum in LEA load and LEA view, and also penetrating the system towards the spine in LEO view. Okay.
We don't see the LEO view. Oh, yeah, no, we can see it. Yeah.
Here, see an LEO view.
But this is the final after the atrial lead position.
Yes. And the final ECG, it is perfect. RSR dash in little r in V1, and also R dash in V1, and also it's very narrow complex here in unipolar configuration. Okay, I think peak RWF time almost less, around 70, 72 that I was remember. And here's the programming, okay, in our clinic. See, we are doing, first we will do a pacing threshold for RV. Here, if you notice that we are doing pacing threshold in bipolar configuration, okay. 1 volt still capturing, 0.75, 0.5, and loss at 0.25. And we will change to unipolar pulse configuration. Here also, we will start 1.25 capturing, 1.75, 0.5, and 0.25. If you see here, wait, sorry. What I mean here, if you note the patient name, okay, and the note left bundle area pacing, okay, we should wrote this in every patient. We have left bundle area pacing. If this patient travel abroad, go to another doctor, the doctor should note that this patient had a dual chamber pacemaker with left bundle area pacing. We will continue. So threshold unipolar and bipolar both are 0.5 at 0.4 millisecond. Here we start sensing patient had a complete heart block. R wave more than 12. Impedance was normal. And battery is 10.5 years. We will adjust parameter here. We will activate the auto capture, so the amplitude decrease from 2 volt to 0.6 to 5 volt. Will increase the battery longevity for sure, and make the atrial lead only monitor. And we change the pulse configuration here from bipolar to unipolar. And there is R wave, small r in lead 1, as you see, but we cannot judge on this surface ECG connected to the programming. Our judgment it will be on mainly on ECG. But here also you saw that the QRS complex, even in ECG connected to programming, is different during pacing. And you are activating now auto capture. Programming. And here's the final parameters. We make it monitor in atrium and then off again. And we will decrease the amplitude for the atrium later. We check the threshold first in DDD, as the patient had a complete heart block. So atrial pacing, capturing 0.75, 0.5, 0.25, and loss at 0.25. So our threshold is 0.5, right atrial threshold, and we'll adjust on parameters, decreasing the amplitude to be double the threshold. And here we check the episode. She had an atrial tachycardia, non-sustained, for maximum duration is 1 minute and 10 seconds. And we say it commonly with pacemaker. Second episode, 4 seconds only. Third episode, 12 seconds. Parameter here, we will decrease the amplitude.
You went to auto capture also. Yeah.
Yes. She is a sinus rhythm, and we want not do the auto capture. Here,
you choose the AV delay 180 and 200?
180, 150 millisecond, and sensed EV delay here.
And the paced?
Paced 200 millisecond, but the patient mainly had all the time signs. Yes.
Okay.
Thank
you very much, Dr. Mohamed.
Take home message.
Yes, please.
Left bundle area pacing benefit provide physiological pacing with lower threshold than his bundle pacing, better electrical parameters than by V pacing, and improved clinical outcome in heart failure patients. Stable parameter during follow-up make it a really a reliable option. Requires challenges require specialized training and equipment. Patient with severe cardiac chamber dilatation may present increased procedure complexity. Emerging trend, ongoing research into optimizing lead design, delivery system, and the programming algorithm, specifically for left bundle branch area pacing. Individual care device programming should be tailored to each patient's specific need with careful attention to QRS duration, EV delay, and output setting. Regular follow-up is essential to ensure optimal therapy delivery and patient outcomes. Thank you.